Hello, and welcome to American CME's Patient Assessment Lecture Part 1. My name is David Mills, firefighter paramedic, and today we will be discussing the benefits of conducting a proper scene survey, how to conduct a scene survey, the components of a highly effective scene survey, and the importance of taking a proactive approach to patient care. Your patient care is only as good as your assessment, and a thorough, pertinent assessment leads to better patient care. A proper assessment provides us the ability to collect information about a patient when other sources of information are limited or non-existent. It can help us to confirm or change our initial impression as care providers. This may also help us to avoid making erroneous assumptions that could adversely affect the patient. A properly performed assessment helps us to establish patient priorities and identify injuries, as well as give us the ability to deliver detailed and pertinent information about the patient's medical or traumatic condition to ER staff. Let's face it, information is ultimately empowering. Our assessments empower us to make the best decisions regarding our patient's care. The moment we stop assessing our patient and the emergency scene is the moment we lose our ability to be proactive, and so we naturally become reactive at best. A reactive approach always seeks to respond after a change has occurred, while a proactive approach produces ongoing positive change via interventions to affect patient care and outcomes. This video emphasizes a proactive approach to patient assessment and care. Patient care without a thorough evaluation is solely based on the provider's assumptions. This can be likened to providing medical care blindfolded. Too often, this great emergency asset, which is our ability to form impressions and make assumptions, becomes our greatest weakness. What we seek to do during the course of this three-part patient assessment series is lay down a framework or skeleton of patient assessment, and then begin to flesh out that skeleton with dynamic qualities that will enable you to adapt your assessment to each unique emergency situation. Our objectives today are simple. By the end of this video, you will understand how to conduct a thorough scene survey, as well as the importance of a thorough and complete scene survey. Before we begin, I would like to discuss two important pitfalls that commonly exist regarding patient assessment that need to be brought to our attention. The first is the contradiction that seems to exist between what is taught in the classroom and what is practiced on the street. The classroom teaches guidelines which find application on the road. If the guidelines are well understood, they can be adapted to any emergency situation without compromising or missing steps. Too often, we compromise these guidelines and take shortcuts, which could negatively affect patient care. By bringing these guidelines to life through practice and then understanding, we can master our craft and fulfill our role as patient advocates. Taking shortcuts or getting tunnel vision after doing an abbreviated assessment is a common pitfall. This can easily take us down the wrong road and cause incorrect or incomplete understanding of a patient's condition, and therefore make our management incomplete or incorrect. Another common mistake is trying to accomplish everything at once without truly looking, listening, and feeling with an understanding of what your objectives are during an assessment. Often, EMTs can become scattered and as a result, miss critical assessment findings. Following an organized and thorough assessment with an open mind about the information we are obtaining can lead us to a correct differential diagnosis. This leads us to proper management of our patients. With these concepts in mind, let's take a look at an overview of a complete patient assessment and then identify each specific part. Ready? Let's get started. A complete patient assessment consists of four main components: Each component builds upon the previous to help narrow down the many possibilities of patient ailments. These four elements are scene survey, an initial assessment, a secondary assessment, and finally, an ongoing assessment. Each of these four components will be further broken down into subcomponents. The subcomponents provide the details and objective actions that need to be taken or considered during an assessment. Throughout this video, we will break down each component, then identify its role within the overall concept of patient assessment. Let's start at the top of the list, scene survey. A scene survey consists of an evaluation of 6 subcomponents that will help you make immediate critical decisions to aid in the proactive care of your patient. During the scene survey, making the correct and most appropriate decisions will not only help improve your patient's outcome, but it will also lay the foundation for your entire assessment by ensuring a safe environment for the emergency response to take place. The 6 subcomponents of the scene survey are ensuring scene safety, taking proper body substance isolation precautions, evaluation of the mechanism of injury or the nature of illness, determining the number of patients on scene, the need for additional resources, and finally, considering C-spine precautions. At the top of the list of subcomponents for scene survey is scene safety. This step initiates the awareness of your safety on an emergency scene. When considering scene safety, look for indications that the scene may not be safe. Also, consider the context in which the emergency has occurred. It is important to note that although scene safety is the first thing we consider, it does not mean it ends at the beginning of the emergency call. Scene safety should always be continuously reevaluated. Indications that the scene is not safe include, but are not limited to, an emergency that occurs in a busy vehicle roadway, fire, toxic chemical release, carbon monoxide, animal attacks, assaults, attempted suicides, highly infectious patients, power lines that are down and arcing, explosive gas and flammable liquid releases. In all these situations, and in those not mentioned, the emergency responder should evaluate the safety of the scene prior to entering it. The rescuer should not subject themselves to unreasonable risks. Remember, we as emergency responders should measure risk versus benefit. Risk a lot to save a lot, and risk little to save little. The days of running blindly towards danger are over. When the scene is determined to be unsafe, the rescuer should determine if there are initial actions that can be performed to stabilize the scene prior to entering it. Some of these actions may include controlling traffic at vehicle accidents, ventilating a toxic atmosphere prior to entry, staging nearby at an emergency scene until PD secures the scene when responding to armed or potentially dangerous patients, utilizing respiratory protection if the patient is thought to be highly contagious, or calling additional resources to manage hazards that are beyond the scope of your resources, experience, or skill. The next subcomponent of the scene survey is body substance isolation, or BSI. BSI is a precaution taken in response to the premise that all body fluids are considered potentially infectious. In all medical emergencies, standard universal precautions should be observed. A minimum level of protection should be taken for every patient encounter. The level of BSI taken should increase as the potential for contact with bodily fluids, such as blood, rises. At a minimum, all EMS providers should wear gloves when in contact with a patient, especially in the presence of bodily fluids. Protective eyewear should also be worn in situations where there is the potential for eye injury from a hazardous environment, or when there is potential of infectious materials being projected from the patient and making contact with the face of an EMS responder. Wear eye protection in situations such as when suctioning or intubating to avoid any fluids or objects in the patient's mouth or throat making contact with your eyes. Or at a vehicle crash when caring for a patient within or in proximity to the vehicle or vehicles involved due to the high risk of eye injury. After we have put on our necessary BSI, we can move on to the reason the patient is in distress. During a trauma, our next step is to evaluate the mechanism of injury, or MOI. Evaluation of the MOI helps us predict injury severity and identify patient priority by evaluating the severity of the forces involved in the event and how they were applied to the body. In turn, that helps us predict injury patterns and helps anticipate patient priority. A severe mechanism of injury may by itself indicate the need for a high index of suspicion for internal injuries even when outward signs of serious injury are absent. For example, when assessing the MOI in a vehicle collision, consider the conditions that may indicate the severity of the situation, such as the rate of travel at the time of impact, the amount of damage to the outside of the vehicle, the amount of vehicle intrusion into the passenger compartment, the direction of impact relevant to the patient, whether or not the patient was restrained, whether or not airbags deployed, was the patient ejected, and are there signs of impact from unsecured items within the vehicle. Assessing a patient that suffered a fall is another example. Consider the height that the fall occurred from, the surface the patient landed on, and how the patient landed, such as head first, feet first, or flat on their back. These are just a few examples of how an MOI evaluation can occur. Remember, by thoroughly understanding the MOI, the care provider can be proactive and anticipate internal injuries and their severity even when clear outward signs of such are lacking. MOI is one of the most important indicators of the type and severity of trauma expected in the patient. In situations where trauma is not indicated, the nature of illness, or NOI, is utilized. The NOI is the initial evaluation of the medical scene in relation to what is causing patient suffering in non-traumatic situations. This is done in order to gain clues or insight into the patient's medical status and condition. Not only is the NOI a medical scene evaluation, but it is also an opportunity to consider all the possible causes for the patient's medical emergency while en route to the scene based on the dispatch information. This step begins to attune the emergency medical responder's ability to decipher the patient's particular set of signs and symptoms. As the assessment begins and continues, possible causes can be ruled out based on evidence or the lack of evidence found during the course of the assessment. Some scene clues that may assist with the care provider establishing an NOI are the presence of medications, drug paraphernalia, empty pill bottles, alcohol containers, toxic chemical containers, or any further evidence that may be related to the patient's complaint. To better understand this concept, let's look at a schematic that demonstrates the flow of how we arrive at a probable cause, or our provider impression, of the patient's medical complaint. We will begin with a visual representation of our overall patient assessment when caring for a patient suffering from difficulty breathing. This upside-down triangle illustrates the natural flow of our assessment, beginning with a broad focus and moving down towards an increasingly narrow focus. At the top of the triangle, we begin with all the possible causes for this patient's difficulty breathing. As the care provider advances through the course of their patient assessment, the possible causes may be ruled in or out based on a careful review of evidence, supporting or eliminating a field diagnosis, otherwise known as a provider impression. Our evaluation of the NOI is important to formulating a list of possible causes. Notice how possible causes of the patient's difficulty breathing are eliminated as we complete our scene survey, initial assessment, and secondary assessment. By eliminating possible causes that lack supporting evidence, we are able to isolate a group of ailments or differential diagnosis that may be the underlying condition that is causing the difficulty breathing. At the end of the assessment, the care provider now finds strong evidence which indicates the probable cause or provider impression. Once we evaluate the MOI and/or NOI, we must then consider the number of patients on scene. Although this step seems straightforward and simple, it is potentially very meaningful. Patient triage, as indicated in multiple casualty incidences, would likely occur at this stage. Triage is the process of categorizing patients based on the severity of their injuries. In addition to triage, this step also allows the care provider to look for subtle indicators that additional patients may exist. Often the emergency medical responder will not consider the possibility of additional patients beyond the obvious. In situations where the possibility exists or evidence indicates that there may be more than one patient, a quick or thorough evaluation for additional patients should be considered. Now let's consider our resources. At this point in the assessment, the emergency responders should have a good understanding of the situation and make a decision to increase their resources on scene or continue care with the current resources in hand. Additional resources can be utilized in a multitude of situations, each of which should be utilized to safely render patient care and maintain safety for the emergency responders. These resources may include PD for scene security or traffic control, additional ALS and/or BLS units for additional personnel, or a need for ALS treatment when only BLS personnel are on scene. Utilities agencies to cut power or mitigate other utilities, or special rescue teams that may be needed to extract patients in technical situations. Even needing help to move obese patients must be a consideration. Calling upon additional resources early is just one way we can be proactive. Do not be afraid to call for them, even if you think there is only a small chance you will need them. Remember, additional resources help keep the patient and emergency responders safe and the scene controlled. The last consideration during scene survey is to consider C-spine immobilization. C-spine precautions should be taken whenever the forces involved in a traumatic incident or injury are considered severe enough to cause possible spinal injury, or there is uncertainty regarding the forces involved. The patient's age and condition should also be considered when evaluating the patient's need for C-spine precautions. When manual C-spine immobilization must be applied, approach the victim from the feet or head and avoid approaching the patient from their side to decrease the chance of the patient moving their head from side to side. The care providers should position themselves so they have access to the patient's head and neck. Once in position, the provider should manually stabilize the head and neck until the patient is fully secured to a certified immobilization device. Check your local protocols for when to initiate C-spine precautions. After considering any needed C-spine precautions, we have completed the scene survey component of our patient assessment. Let's quickly recap. Scene survey is made up of 6 areas of consideration. These 6 considerations come together to complete a scene survey. When conducting your scene survey, first, make sure your scene is safe and secure for both you and your patient. Once the scene is safe, put on the necessary BSI according to the level of protection needed to keep you out of contact with the patient's bodily fluids. Next, consider the mechanism of injury or nature of illness from on-scene clues to formulate insight regarding the possible reasons or causes of the patient's ailment. Once you have identified the nature or mechanism, identify the specific number of patients on scene. After you have identified your number of patients and any other concerns, you should call upon additional resources if needed. Remember, these resources should be utilized to aid in safely rendering patient care and maintain safety for the emergency responders. After additional help is called as needed, you should then consider C-spine precautions for any patient that qualifies per your local protocols. Every emergency scene is unique, and the care provider needs the ability to adapt in order to be successful in their rescue attempt. Adaptability arises from a deep understanding of the guidelines that underlie the steps that were presented in this video. If we as care providers don't just know the steps and their order, but understand the role of each step presented today, their importance, and what they seek to accomplish, then we will be capable of adapting our patient assessment to each unique emergency situation and provide highly effective professional care for those in need of our services. Remember, your treatment is only as good as your patient assessment. That completes part 1 of American CME's Patient Assessment Training video. Thank you for watching and have a great day.